Here, one of the video, you see the device is inserted with, in this case, I'm off pump, and I'm doing a radial artery that comes from the OM. First, I do a stitch, like a regular cannulation site stitch in the ascending aorta. You can do it in the lower portion of the aorta and insert the device from the sinotubular junction up toward the upper portion of the aorta, or you can do exactly the opposite, putting the insertion from the upper portion of the aorta down towards the proximal. Now I put that little needle in the aorta, you see, and then after the needle, I insert the device. This is how the device presents itself. You see there is an upper jaw and a lower jaw. You insert the device inside. I show that there is a good patency. I'm inside the aorta. And then I lower down the stitch of the purse string, like a regular aortic cannulation, something that everybody can do, something that everybody is familiar with. After that, I basically work on the two different jaws that are present. So one is the gray one and the other one is the yellow one, the two different elements, capable of basically creating and sealing the ascending aorta. You see, first, I open the device with the gray, and then I lower the device with the yellow. And now I created a sealed site for my proximal anastomosis. I can open the aorta there, and there will be no blood that comes out from the aorta. A complete sealed, touchless, minimal touch aortic technique that allows you to have a very safe proximal anastomosis. And now you create a proximal anastomosis like we are all very familiar with. You do the opening of the aorta, a punch, you do your hole, and you do your proximal 6-0. This is what I use, and whatever you guys are familiar or whatever you like to use. Proximal anastomosis. In this case, is a radial, can be a vein, can be whatever conduit you like to use in your clinical practice. And you finish the device, and then you remove the device off of the aorta, allowing you to perform the final site. There is a membrane, of course. Don't be too deep in the way in which you're passing the stitch. You need to be, of course, full thickness, but you don't want to perforate the membrane because otherwise you have the blood that comes from the aorta back. But the anastomosis is something that I let my resident do, and it has the same complexity of a proximal anastomosis performed in a different way. In one way, I almost like it more than a side clamp, where the hole in the side clamp sometimes is all stretched by the clamp itself. And then I remove the device out from the aorta, I reopen the purse string, and I basically remove the device. Now I'm closing the bypass, actually. And then removing the device from the aorta and let basically close the aorta itself on the purse string that you have done. You see, and now you close the aorta, you remove the device. Same situation, and you remove the device, and you close the purse string in the same way in which you close the purse string of an aortic cannulation. But the needle is extremely low, is extremely small, and the aorta is minimal touch. And again, you have a very nice closure. You see again